So I'm going to talk about risk factors for abnormal knee laxity after primary ACL reconstruction. And first of all, we have to define what abnormal knee laxity is. And if we look at the IKDC form, and in particular the ligament examination form, we can see that if we measure the laxity with instrumentally with 134 Newton of anterior tibial displacement, so we can classify laxity in 4 grades, with the abnormal grade being a side-to-side difference between 6 and 10 millimeters, which corresponds to a Lachman 2+. And the severely abnormal grade, which is a side-to-side difference more than 10 millimeters, which corresponds to a Lachman 3+. So everything which is a side-to-side laxity more than 5 millimeters is considered abnormal. So we published this paper in Arthroscopy, where we looked at the risk factors for abnormal anteroposterior knee laxity after primary ACL reconstruction, and we included all primary ACL reconstruction performed at Capio Arthro Clinic from 2000 to 2015 with no concomitant ligament injuries. So we started from an initial cohort of 7,185 patients, and we excluded patients with the contralateral ACL injuries or reconstruction and patients with the missing pre or postoperative KT1000 values. So we got a final cohort of 5,462 patients. We used, as I said, the KT1000 arthrometer with an anterior tibial load of 134 Newton, which corresponds to 30 pounds. And we look at the side-to-side difference preoperatively and at 6 months follow-up. We dichotomized the postoperative side-to-side difference in less or equal than 5 millimeters and more than 5 millimeters, considering this one as abnormal. We used a logistic regression analysis to identify preoperative and intraoperative risk factors associated with abnormal knee laxity. We investigated several variables. Among the preoperative variables, we looked at age at surgery, gender, preoperative side-to-side difference, and among the intraoperative variables, we looked at graft type, hamstring tendon, and the bone patellar tendon bone autograft, with the first one being predominant, and medial meniscus surgery, resection or repair, and the lateral meniscus surgery, resection or repair. Here you can see the mean and standard deviation of postoperative side-to-side differences in millimeters. We found a total of 223 patients, so about 4% of the entire cohort having a side-to-side difference postoperatively, 6 months postoperatively, more than 5 millimeters. And we found that age less than 30 years was a risk factor. Female gender did not affect the risk. Preoperative side-to-side difference more than 5 millimeters was the strongest risk factor for having abnormal postoperative knee laxity. Hamstring tendon autograft over a bone patellar tendon bone autograft was also a risk factor, as well as medial meniscus resection. Medial meniscus suture, lateral meniscus resection, and the lateral meniscus suture did not affect the risk of having abnormal knee laxity. So age less than 30 years, hamstring tendon autograft, medial meniscus resection, preoperative side-to-side difference more than 5 millimeters are associated with an increased risk of having abnormal knee laxity after primary ACL reconstruction. So why younger age? So we hypothesized that probably older patients have a stiffer knee due to progressive osteoarthritic changes. That is a possibility. Another possibility might be that there is a graft elongation due to a more intensive and aggressive rehabilitation in younger patients. That should also be considered. And our results are in line with the results by Marchand in this paper published in Case Study. They found also greater residual laxity with 134 Newton anterior tibial load displacement at an average of 26 months follow-up after ACL reconstruction in patients younger than 20 years old. So we and they also hypothesized that probably we should delay weight bearing, should use maybe a brace or slower rehabilitation during the first postoperative months. That's a possibility. Regarding the hamstring tendon graft, so we looked at the differences in graft laxity in a separate study we published in CASTA. In this study, where we evaluate 5,500 patients, so we compared hamstring tendon with the bone patellar tendon bone autograft, and we found that the postoperative side-to-side difference was significantly higher in patients who received an hamstring tendon autograft. On the other hand, the anterior tibial translation reduction was significantly higher for the bone patellar tendon bone graft. So this graft reduces laxity more effectively than to a higher degree compared with the hamstring tendon graft. Also, if we look at the stratified KT1000 arthrometer side-to-side values according to the IKDC, the number of so-called surgical failures side-to-side more than 5 millimeters was significantly higher in hamstring tendon group compared with the bone patellar tendon bone group. And these differences are probably due to the differences in healing at the healing interface in the bone tunnels. So the hamstring tendon graft needs the formation of sharpest fibers to heal, and the sharpest fibers formation occurs somewhere between 8 and 30 weeks after the surgery. And if we look at this figure, the pull-out strength of the graft correlates with the number and size of bridging sharpest-like fibers, which is complete at 3 months postoperatively. So probably during the first 3 postoperative months, there is a higher likelihood of bone of graft tendon slippage, of graft slippage in the hamstring tendon group compared with the bone patellar tendon bone group, where the healing occurs much faster. Regarding the effect of the meniscus on knee laxity, we investigated the effect of different kinds of meniscal surgery on knee laxity in a separate paper which we published in AJSM. And in this paper, we found that the number of surgical failures, so the number of patients with a side-to-side difference more than 5 millimeters, was significantly higher in the group who received a medial meniscus resection in combination with ACL reconstruction. So it was about 3 times higher compared with the control group, which was isolated ACL reconstruction. And also the other group that received the medial meniscus and the lateral meniscus resection had about 3 times more surgical failures compared with the control group, isolated ACL reconstruction. So save the meniscus to preserve knee laxity. So the meniscus, why there are these differences? The differences between the medial and the lateral meniscus in preserving knee laxity are explained by the geometry of the medial meniscus. So the medial meniscus, in particular the posterior horn, acts like a wedge, and it resists anterior tibial translation. So it's extremely important as a secondary knee stabilizer. And this paper by Papageorgiou showed that also there is a strong biomechanical interdependence between ACL replacement graft and the medial meniscus. And if we remove the medial meniscus, there is an increased stress, an increased force at all flexion angles in the ACL graft. So there is a higher risk of failure. And in fact, in this paper by Rob in published in Case in 2015, so the authors found an increased risk of ACL graft failure with when the meniscus was deficient. So medial meniscus deficiency and the lateral meniscus deficiency was the only risk factors for having an ACL graft failure, which was defined as abnormal knee laxity or as a graft rupture. Regarding the importance of a preoperative laxity, I showed you in the first slide that preoperative side-to-side difference more than 5 millimeters was the strongest risk factor for having abnormal postoperative knee laxity. In this paper we published in Arthroscopy, delayed ACL reconstruction increases the risk of abnormal pre-reconstruction laxity, medial meniscus, and cartilage injuries. What we found was that patients who waited more than 6 months from injury to ACL reconstruction had a higher risk of having abnormal pre-reconstruction laxity compared with the patients who got early surgery. So the reference group was between 0 and 3 months from the ACL injury. So also surgical timing is important in reducing the risk of a preoperative knee laxity, which in turn is the most important factor affecting postoperative knee laxity. We found also that a BMI more than 25 reduced the risk of having abnormal pre-reconstruction laxity, and as expected, medial meniscus injury was a factor that increased the risk of having abnormal pre-reconstruction laxity. Thank you very much.